So as we've been hearing all weekend, image acquisition and processing is essential, especially when we're trying to image things as small as the coronary artery wall, which can be sub-millimeter. So it's critical to pay very close attention to our parameters when we're doing CT calcium scoring or angiography, including optimizing patient preparation and optimizing our sequence parameters. And as well, although MRI is not used very often clinically right now, a lot of us are playing with whole heart angiography and single slice black plug imaging, and similarly it's very important to be aware of all the different parameters that affect our voxel size and our contrast. So if I showed you this image, most of you would automatically feel a little bit uneasy. Is this an area of focal stenosis? And so on this curved multiplanar reformat, most of you would say no. And you would say no for good reason. This is just a curved multiplanar reformat where the center line has been inappropriately put to the wall. And I think most people can recognize that automatically, even without seeing these other views, because there's no plaque associated with this apparent area of luminal narrowing. And so even though we don't report it clinically, a lot of us are already analyzing plaque when we make decisions regarding the extent of stenosis that we're calling in our CTA reports. So plaques are often characterized according to their location, their distribution, and the density. We report the Engaston score as part of our coronary calcium scoring, and we're often describing whether or not the plaque is punctate or diffuse throughout the vessel, and some of us are commenting on attenuation. If at all, we're at least usually giving the dichotomy or the discrimination between calcified and non-calcified disease. And so this is just an image where this patient has a chronic total occlusion of the distal LAD. And at our institution, the cardiologists who are doing interventional work are very interested in having a description of the length of these lesions, the extent of calcification, and their relationship next to branch vessels, which often determines whether or not they'll be successful at crossing this during an intervention. So coronary arterial calcium scoring has been demonstrated in many very large clinical trials to be an extremely strong predictor at the population level for significant stenosis in symptomatic individuals. And so this graph is from the confirmed study. It demonstrates the distribution of coronary calcium scoring and the presence of significant stenosis at these different levels of coronary calcium score. So patients who have a 0 score are very rarely have any type of significant disease, although it has been seen they can have non-calcified plaque. And patients that have a very high coronary arterial calcium score very rarely have a normal CTA. And so if we look at the incremental prognostic value of CCTA in addition to coronary calcium score, we can see that in these large cohorts, like this group of more than 8,000 symptomatic individuals who were followed for 25 months, that 150 patients died or had a cardiac event. And so when we try to dichotomize the coronary calcium score into that group of patients who had a 0 score, just over 50% of the cohort, and patients who had a score of more than 400, so just less than 10%, and those with positive coronary CTA, described as either being normal, so no disease, or having near occlusion or occluded vessels, we can see that when we add to sort of a baseline risk score consisting of Framingham risk factors like age, sex, diabetes status, smoking, and cholesterol and hypertension, when we take this baseline risk and we add our coronary arterial calcium score, we get a statistically significant increase in our region under the curve in terms of identifying who will have significant disease. And similarly, when we add the coronary CTA data, this also increases our ability to predict who will go on and have a significant event. I think that this intuitively makes sense to us. Back in 1978, Glagov published his vascular remodeling theory, and these are based on his observations of pathologic dissection of coronary vessels in cadaver specimens, and his identification that plaques initially result in positive remodeling or expansion of the outer wall due to increased volume within the wall with a relative preservation of the lumen. And we often encounter this in daily practice we will define a plaque where we perceive a stenosis, and then our colleagues in interventional cardiology will come back and state that they see nothing. But of course this is the case because we're seeing the outside of the wall, which they are blind to, which we all recognize very readily in this room. So after this minimal stage of disease, there's an inflection point that gets reached where the extent of disease within the wall starts to encroach on the lumen itself, and then eventually you'll also get surface defects and irregularity and ulceration at the surface level. So if we consider things that are high-risk features, these have been identified quite readily in the literature over the last 10 years, including, as Glagov described to us, positive remodeling, the presence of a lipid, plaque, or necrotic core, which on CT we often identify as having a Hounsfield unit of less than 30, or having spotty calcification. And so Joan Laconis gave me this beautiful picture, and you can see that this plaque demonstrates all three characteristics. So with relative preservation of the lumen, we see that there is extensive positive remodeling with extensive eccentric plaque, that this plaque is very mottled, it's got a mixed density to it, where there are low density portions and also this spotty calcification. The interesting and sort of intriguing part of spotty calcification is often when we're trying to do our Gadsden score, even if we draw a region of interest around here, we don't pick it up. And that, again, is a reflection that the Gadsden score involves a combination of both the density of the plaque and its area. So often the spotty calcification doesn't meet the minimum cutoff to be included in the Gadsden score. Moiriyama in 2007 presented two groups of patients, those with acute coronary syndrome and those with stable angina. And he looked at many of these characteristics in addition, with a few others in addition, and demonstrated that there was a great discrepancy in the extent of disease and the disease characteristics of the plaques identified in these two groups. So again, positive remodeling was associated with the acute coronary syndrome patients. This low density, less than 30 Hounsfield unit plaque were seen much more commonly in these acute coronary syndrome patients. Interestingly enough, this intermediate plaque that ranged between 30 and 150 Hounsfield units, which we often kind of attribute to some type of fibrous, more stable material, was seen in both and in everyone. The presence of spotty calcification, again, was very common in the acute coronary syndrome, and large chunky calcifications, large sort of long-distance plaques, were much more common in the stable angina patients, possibly reflecting the fact that these large plaques represent sort of healed or chronic disease. Recently published in another group of patients, this is a cohort of about 50 patients, 25 in each arm, one group who had non-ST elevation MI and the other who were unstable angina patients, looking at these same characteristics, so low density plaque, positive remodeling, and spotty calcification, that both these characteristics were identified in both groups of patients. But interestingly, when you combine these features, having all three features was much more highly associated with being in the NSTEMI group. And so again, a reflection that these are in fact likely characteristics of culprit lesions and unstable plaque. Another thing that's been widely described in the literature and is very interesting is the Napkin-Ring sign. And this is sort of a combination of some of the features that we've previously been describing. So this is a figure that was taken from this article that was published in JACC Cardiovascular Imaging. And we have a calcium score, so a non-contrast enhanced CT, which demonstrates this area where we get a hypodense, sort of central necrotic plaque, and it's surrounded by an area of relative hyperdensity. We see contrast within the lumen on the CT angiography portion of the exam, and then we actually have histology as well. And the histology demonstrates sort of the devoid of signal after the extraction of the fatty component of this plaque, and it's surrounded by a fibrous component, and generally what it's considered to be is sort of the low density core surrounded by rim-like high density, which can be a combination of neovascularity within the fibrous cap as well as microcalcification. So the thing that's been alluded to yesterday as well as earlier today is that we don't have any standardized methods for describing these. So although we, as demonstrated by our opening case, we are constantly looking at these features and making our decisions as we report our CTAs based on our evaluation of whether or not plaque is real or artifact, and these characteristics can definitely help in that decision. We don't have any standardized methods for acquisition that help us very routinely and sort of standardly describe and attribute the additional prognostic risk associated with these plaques. So I think this is something that will be coming up in the next few years. Various studies, including this one by Hoffman, has demonstrated that often we can only reach moderate interobserver agreement when we're trying to describe these plaques. And even our semi-automated techniques can disagree quite often because there's still a lot of correction that we need to do manually, which can lead to a lot of variability within and between observers. And so this is my single slide of magnetic resonance imaging. This is an area of ongoing active research. A lot of people are starting to adapt whole heart angiography as a way of characterizing luminal stenosis. And as well, I think related to the time involved and the sort of the time-intense nature of this technique, most people are only able to do single-slice black blood imaging to characterize the lumen. But it's very interesting because when we do, we can often identify these eccentric plaques with sort of lipid cores. And so that's the end. So thank you very much.